Minutes for your questions, please.
Thank you, Mr. Chairman. Dr. Bannon, good to see you here. We were taking a little friendly wagers up here to see if you had your boots on or not. I said yes, and you probably got your cowboy hat outside too. So do appreciate the knowledge that you bring, and thank you so much for coming up here. I know it's hard to leave our beautiful state, especially where we live, right?
That's right.
Dr. Martz, I want to dig in a little bit on some stuff that you've been saying. And I respect your opinion, but I have a problem with the fact that you're trying to push it off as facts. When we start talking about privacy, I just want a yes or no here because you kept referring back to this. Is it legal for treatment to be shared with an employer right now? The answer is that is no. So is it legal? Yes or no?
There are conditions with which you can make a release.
Only if the individual has consent. Don't mix words with me, yes or no. Is it legal or no?
In that condition, no.
Right. I'm an employer. I have several hundred employees. It's completely legal. Second, I'm also a landlord. Is it legal for treatment information to be shared with a landlord? Yes or no?
No.
No, it's absolutely not. Is it legal for information to be shared in a criminal case or a divorce hearing? No. So what you're saying about privacy is completely irrelevant to what we're trying to do here. This is about patient. It's not about opinion or maybes. It already is illegal, and underneath the legislation, it stays illegal. So when you're testifying with us, please be a little bit more factual on what you're saying instead of making a broad statement like that and drawing fears into people. We bring you here because you are considered an expert. Please be that expert. I know you got a wealth of knowledge up here, but you're misleading us and the panel when you don't put facts with it. Second of all, you start talking about the stigma that's put in place, and you've referred back to SAMHSA several times. I sent a letter to the Assistant Secretary asking for their information on our bill and what their thoughts were. Let me read you a quote that came out of it. This is my favorite letter that when they sent it back. It said, "The practice of requiring substance use disorder information to be any more private than information regarding chronic illness, such as cancer, heart disease, may itself be stigmatizing." That's from SAMHSA. Pretty plain and simple there, that they think it's itself. It shouldn't be treated any different. Now let's talk about the fines, because you brought up fines about this. How many, underneath Part 2, how many penalties have been issued underneath Part 2 for violation of Part 2?
On federal or state level? Because there
Federal.
are sanctions against licenses on the
Federal.
level.
Federal.
Not that I'm aware of.
2. How many has been brought up underneath HIPAA?
That's outside of my scope.
Let me just kind of put this out there. 173,426 since 2003. Now, why is that? Because you talked about this in your opening testimony, and I just want to make sure that we're factual here so you understand what we're talking about. A lot of people want to talk about privacy and about not providing or not separating or why Part 2 and HIPAA needs to be separated, but underneath Part 2, the penalty is $50 if that information is mishandled with the patient, $50. It's not worth the court's time to deal with it. It's only 2 cases. Underneath HIPAA, it ranges between $150,000 per violation and a maximum of $1.5 million per year. This is about patients. What we're trying to do here is treat the patient. But how can you treat the patient when the doctor can't see all the medical information? How can you do it? And the reason why I'm so passionate about it, because it touches my family. We're currently dealing with it. I currently dealt with a situation yesterday over the phone. Because we have a family member that has a disorder of being addicted to drugs because it started with a elective surgery, and now her life is completely ruined, and she keeps going to doctors, and they keep prescribing her stuff. And they can't see her complete record and how many times she's been in treatment. And so every time she goes in, they start prescribing her more pain medicine because she's in pain. Well, what's the difference between pain and a withdrawal? Because at some point you start coming off of it and you start having withdrawals, and guess what? That's painful too. And so we're talking about combining those two. Are you following me on this? Mm-hmm. So what is wrong with my legislation that allows a patient to be treated completely? And don't tell me about the stigma, because it's not about stigma, it's about treatment. It's about getting the patient back to who the person they were before.
Thank you for your passion and information. I fully agree with your the points that you're making. Would add respectfully a couple of points in addition to that. In good clinical care and for the treatment of the use disorder, okay?
Make it short, because I didn't know I was already over time.
Sorry, thank you. It's critical to have that patient be involved in that collaboration so that there can be the best collaborations. And
they're seeking more treatments because they're addicted to drugs.
Which will all be noted in the PDMP, where they will all have access to that already information.
Which is important for the doctor to have the same information. That's why we're trying to compare the two and make sure that both of them are combined so the doctor can give the patient the treatment they need. They're professionals, just like you're a professional. I yield back.
Chair, thanks, gentlemen.
For your continued effort on holding these hearings. It means a lot to me and so many other families. Thank you for the panel for being here too, and sticking with us. It's been a long day, and so I do appreciate it. Stacy, thank you for working with us on the IHS task force, coming in and talking to the staff just Monday, and educating us and working with us, trying to figure out how we can help better serve Indian country as a whole. And as you said in your testimony, that it's disproportionate high of accidental overdoses inside Indian country. I represent the great state of Oklahoma. I'm Cherokee myself, and you know, I have the highest Native American population of any district, and so this hits home really tough. And you know, part of what we're trying to do is make sure that it's not overlooked. Tribes are unique because we're considered sovereign nations. And so by getting funding to Indian country is vitally important, because most health care for Native Americans are done within the IHS system. That was a federal government obligation through the treaties to which they were signed. And I understand most people don't understand that, but it's where I grew up my whole life. I'm still living in a country, still live at the same place I was raised, and my family was raised. We're generational there. I got a question for you though. What are the benefits to direct funding the tribes throughout this program?
Thank you, Congressman.
No, thank you.
Well, first of all, directly funding the tribes upholds the federal government's trust responsibility, and as you so eloquently expressed, the promises that were made in the treaties to the tribes. The trust relationship that is established through the Constitution, federal law, and so forth is a relationship between the federal government and the tribes. When funding for programs is sent to the states with the hope, or maybe even the intention, that the state will share that funding with the tribes, there's no legal obligation and there is no accountability whatsoever on whether any of that money will reach the tribes. And that is largely because the trust responsibility cannot be delegated to the states.
Right.
It has to be honored at the federal level. So the benefits are tremendous. If I may, Special Diabetes Program for Indians, it's not a large investment from the government to the tribes, but it's a public health program that is taking the best of Western medicine and the best of tribal traditional practices and implementing a prevention and treatment program that is probably, after immunizations, the most successful public health program in the country. The tribes know how to do this.
Right. And I want to elaborate just a second on what you said. It's not their obligation. It is not the state's obligation. The treaty was made with the federal government, and it's not a handout. It's payment from land that was taken from the tribes for years and years ago. And that obligation and that payment still stays in place. And for tribes to be able to ask the state for it, the state does look at it as it's not our obligation, which it's not. It's not any fault to the state. Oklahoma deals with this in a very unique way. I have 19 different tribes just in my district. And we have a unique relationship with the states, but we do have to realize that through the grant programs, they need to be available to the Indian country also. So one more question for you. Can you discuss the technical challenges that we have that's hampering Indian country with getting the data and the information that they need?
Yes, I can talk about that briefly. The health IT system in Indian country does not have great interoperability among the various electronic health records and so forth that the tribes who are self-governance may choose to use an application that's different from what the Indian Health Service uses, which is the RPMS system. And the RPMS system is, it's very cumbersome in terms of trying to extract data and trying to make the picture that you actually want to make out of the disparate ways that data is collected. There needs to be an investment in Indian country to advance electronic medical records. The agency, I believe, states it would require $3 billion over 10 years to bring that system into par with what the rest of America is experiencing.
Thank you so much. My time is out. Thank you, Stacy, again for working with us. Thank you, Chairman. I yield back.
Chair thanks the gentleman. Chair recognizes the gentleman from Maryland, Mr. Sarbanes. 5 minutes for your questions, please.
Thank you very much, Mr. Chairman. I want to thank the panel for very compelling testimony. I wanted to focus particularly on H.R. 5102, which has been mentioned. This is a bill